All right, welcome back. We just had a quick break to ensure our legislative council could draft some language. So it is not posted yet, but she will walk through it with us and then we'll make sure everyone has a copy and we get it posted.
Great. All right. Good afternoon. Jennifer Carby, Director and Chief Counsel, Office of Legislative Counsel. So I am going to put my language up on the screen. So I've created a new 3.1, which I will send to Claire afterward. And so just to orient us to where we are in, the actual language is going to show up in a couple of pages, but we're in Act 91 of 2020 as amended by a bunch of acts. We are in section 17 of that on regulation of professions and extending the deemed licensure for out-of-state healthcare professionals and through March 31st, 2024. This is the language we had looked at last time that was narrowing the scope for professions regulated by the Office of Professional Regulation, just to those for which the office does not provide a pathway to provisional licensure. So I've unhighlighted that. But the language we talked about today affects on page 8 that new language we added as a subsection F that directs healthcare facilities, health insurers, and Vermont Medicaid to, and it says shall, consider deemed licensure, certification, or registration pursuant to this section as sufficient to meet applicable Vermont licensure, certification, or registration requirements for the purpose of healthcare professional credentialing and enrollment. And then here's the new language. Provided, however, that this deemed satisfaction of the licensure, certification, and registration requirements shall have no impact on any other credentialing or enrollment requirement. Sorry, it breaks across 2 pages.
Any questions? Everyone's shaking their head yes in the seats. Okay.
Okay. And then the other piece that we just added actually goes in a different section. It's going to go in a new section 4 of this bill, and it is amending Act 85 of 2022, Section 6. Act 85, as we've talked about, was last year's COVID flexibility extension bill, and it had created kind of an intermediate step in getting from where we were with some of the deemed licensure to a full telehealth licensure and registration system. And so it had some temporary time limited kind of intermediate telehealth registration process. And so here it would be amended to say, so that language, the language from that act said, notwithstanding any provision of our professional licensure statutes or rules to the contrary, instead of saying from the period beginning on April 1st, 2022 through June 30th, 2023, which is what's currently in place, this would just say beginning on April 1st, 2022, without a date certain end date, but you'll see there's more language coming. So for the period beginning on April 1st, 2022, this would continue to allow OPR and the Board of Medical Practice to register a healthcare professional who is not licensed or registered to practice in Vermont, but who wants to provide services to patients or clients in Vermont using telehealth, would require them to register that healthcare professional to provide telehealth services, provided, and then again, this is the existing law, but it's currently set to expire at the end of June. As long as the healthcare professional completes an application in the manner specified by.
We can't see it. I don't think.
Did it stop moving?
Are we in the right section? Okay, sorry, I guess I'm just not following.
Yes, right, I'm trying to get you to what's required.
Sorry, okay.
The existing law.
Sorry.
So as long as the healthcare professional completes an application process, an application in the manner specified by the director of OPR or the Board of Medical Practice as applicable, and that's because of the different provider types. And the healthcare professional holds an active, unencumbered license, certificate, or registration in at least one other U.S. jurisdiction to practice the healthcare profession that they're seeking to provide telehealth services in Vermont. Their license, certificate, or registration is in good standing in all other U.S. jurisdictions where they are licensed, certified, or registered. and the healthcare professional provides verification of licensure, certification, or registration to OPR or the Board of Medical Practice. So here's the new language. This would now say, potentially, the temporary telehealth registration option available pursuant to this section shall continue to be available to out-of-state healthcare professionals until the telehealth licensure and registration system established in 26 VSA, that should be chapter 56. Nope, still can't take, and talk, chapter 56 by Act 107 from last year, which is what established that, is operational. So this option, temporary telehealth registration option, will continue to be available until the full telehealth licensure and registration system is operational. And then it would direct the Office of Professional Regulation and OPR to provide appropriate notice to healthcare professionals registered under this section of the expiration date of the temporary telehealth registration option. So that's language similar to what you have in the deemed licensure about notice. Provide appropriate notice of the expiration date of the temporary option and shall allow temporary telehealth registrants a reasonable period to transition from temporary registration to a telehealth license or registration under that chapter. So meaning just because it's operational doesn't mean they shut the lights off and the temporary registration ends. They would get provide some period of time for those out-of-state registrants to transition. Yes.
And Devin Green from the Vermont Association of Hospitals and Health Systems. We heard from David Hurley.
I got something. I couldn't read it.
Yeah. He would like to see 90 days just to make it specific in terms of transition time, and Jessa and I are okay with that.
The committee okay with, instead of providing a reasonable period, we would say shall provide residents 90 days.
Makes sense.
I think so.
Yeah.
All right.
That, you're saying once it's operational?
Yes,
Okay, got it.
The transition.
Yeah.
to transition.
Yes.
And is so the language is clear that it's operational, right? Like
I said until it is operational, and providing appropriate notice to healthcare professionals of the expiration date of the option and allow 90 days to transition from temporary registration to a telehealth license or registration. Do we
the
need
other
to?
thing that David Hurley asked for was just to put telehealth registration in the last line instead of the new chapter 56, because there are lots of different options in the new. I
don't know what that means. I don't know what that means.
So why don't we take that offline? Because we'll.
Yeah.
As long as I can look at my email while you talk, as long as it doesn't show up there.
Okay. So Leslie?
I don't know what the backlog would be of the number of people OPR would have to deal with in 90 days. And is that a reasonable request?
Well, they're the ones, Board of Medical Practice is making the request. And so we have an email out to OPR as well. So
Okay, so that would be my, as
Yeah,
long
right.
as we'll see that they.
they'll see this language and react to that. Yeah.
Not sure what the other options are. We'll discuss. I'll highlight this in a different color so I don't forget.
And we're not voting on this today. But we do want to get it out next week because of the March 31st deadline. So any other questions on any of this? Yes.
Would it be appropriate to put something in there that the General Assembly would like to look at what pieces of this should be permanent so that we can consider them for 2024?
So Jen can answer, but I don't think that's appropriate for necessarily statute. I would also say people who would be requesting the permanency are sitting in this room.
Well, something like.
And I think us saying that, the fact that we will be back in this, so if it wasn't this group coming back, I might have a different answer. This group is coming back. This group will be reviewing this potentially in 2024 unless everything just is going to expire. And sometimes it's enough to just say, we would like those who might come back to request an extension to instead talk to us about
Okay.
expiring or making permanent.
All right.
And those people are shaking their heads. Go ahead.
Devin Green, Vermont Association of Hospitals and Health Systems, and I think that work is happening already. We're seeing that with OPR and the way they're fast tracking licenses, and we're hoping to work with the Board of Medical Practice to
Okay.
help
Yeah, no,
make the
right.
licensure a little more modernized. So
Okay, thank you.
we are making progress.
All right.
Thanks, Art. Okay, so Legislative Council will work on that last little piece. We do have this on the schedule for next week. I forget which day. We'll let you know. But we will mark it as a vote on that day as well. So just everyone be prepared for that, but we'll obviously have a committee discussion before we do the vote. Great. Thank you, everyone, for getting that all resolved. So we are in our last hour for the week, and we are switching to the governor's proposed budget on Blueprint. Earlier, we heard from the Blueprint themselves on the proposal, and now we have several providers with us. And I think, hold on, I gotta get my agenda. I think, thank you, Jen. Yeah, so we have several providers with us. So we have Ashley, Kristen, and Peter. You're not Peter yet. Okay, so, sorry, I was just confused for a minute because there's two of, is it Kirsten? Am I saying that correctly? Kirsten?
Kristen.
Kristen. Okay, sorry. So we have two of you, so that just had me confused for a minute. So Peter, I'm sure will come in. He's last on the list. So if Ashley, I think we have you first. If you want to state your name for the record and then provide your input on the proposal, that'd be great.
Hi, my name is Ashley Miller. I'm a pediatrician down in South Royalton Health Center. I give you a brief overview of who I am. I grew up in New Hampshire, but moved up to the Upper Valley for medical school. So I've been here since 2002. I've worked in South Royalton since 2014 and actually became the practice owner a few years ago. So very dedicated to Vermont and all the wonderful things that we can do. We have a little bit of an interesting business model since we are a small private practice. We're able to do co-located mental health. So we have a counselor that works with us, and also through the Health Hub, our nonprofit branch, we're able to provide care in school clinics. So we have about 10 or 11 schools right now that we serve. We can do acute care, well care, chronic care in school to help families miss less work, kids miss less school, and have closer follow-up so they're ready to learn. And part of our model also, we're able to have a care coordinator, which is actually paid through the community health team funds that funds her salary. And she's been able to do amazing things over the last few years. She really works on what we consider social determinants of health. So things like food security, housing, transportation. We've been able to establish a diaper bank at our location. We've been able to fund some gas cards. So people needing to either come to us or go to DHMC or UVM, we can help support them with gas. She does our PCMH, so our patient-centered medical homework, helps us on quality improvement projects, which recently has looked at both depression, ADHD, developmental screening, ER utilization, referrals. I think the biggest thing for us is these community health team funds have allowed her position to be possible, but we need like 3 of her now. So many of you are probably aware of the mental health crises in the state, particularly with teens, but we're even seeing it in our younger children, families feeling isolated, not having the village to raise, their kids with, to have that support. So she spends a majority of her time right now just connecting people with resources. So connecting them with counselors, trying to find a counselor that takes their insurance or is accepting new patients or can do telehealth because there's no one locally or they have transportation issues. She's been helping them find connections with parenting models. So we found a wonderful counselor who was trying to retire, but agreed to keep seeing patients for us, who has been working on attachment parenting and parent behavioral management training. So these are things that usually aren't paid for by insurances because it's really helping the family and the parents. So trying to be creative about using our health team funds to help support that as well. She also helps families go to 504 meetings, IEP meetings, and then she follows all of this up to make sure those connections were made, that parents don't have further questions, really offering her services as much as she can. So with the ability to expand these community health team funds, it would be hugely helpful. Hopefully being able to provide more mental health workers, so more than the counselors we have currently, to focus maybe on group therapy. So we've been talking about shorter, very specific skill building classes to make available for both parents and for teens. So like your anxiety groups or your DBT groups, in hopes that preventative mental health care, just like preventative care medicine, can help us keep from getting to the crisis area with anxiety, depression, self-harm, substance use. So super supportive of increasing any funds that we can. I love the community health team model. We're excited that this is a possibility. And then also, you know, patient-centered medical home, Blueprint funds, Medicaid payment levels, anything that you can do to help us. We're really in crisis, and the supports can severely impact the health of our families and patients in a great way. So thank you for taking this under consideration. I'm happy to take any questions, and I'm happy to share my email for the future as well.
Great, thank you very much. We'll take a couple of questions before we go to Kristen. I have one, but I will let others go first if there's any questions. No? So my question is, you mentioned at the end, Medicaid rates, anything to help primary care. And in this proposal, there is no increase so part of my question I'm going to set out for the committee as well. So in the proposal, there's an increase to increase the community health team payment. Blueprint also has, if you remember from the presentation, a payment to the provider who is part of the Blueprint. And that piece is not part of the proposal to increase. If that was increased, how could your practice use additional funds? What would the benefit be?
Yeah, that's a great question. So I'm really invested in patient-centered medical homes, and I think providing as much care as we can co-located is super helpful to families. So, I mean, one of my pie in the sky views would be, could we provide some nutrition classes? Could we actually have a dietitian co-located, like we're having mental health counselors co-located? So those Blueprint funds can be super helpful for any of those sorts of other options. But honestly, right now we're in such crisis that it would just help me pay my staff enough to keep them here. So part of our issue as a small practice is we find wonderful people, we can pay them what we can pay them, we train them all up, and then sometimes they're harvested away by some of the bigger companies that can pay more. So, I mean, it is nice because we have a wonderful core dedicated staff that isn't here for the money, they're here for caring for patients. But even just being able to compete with the areas around us with what we're paying our staff will help keep the quality staff that can provide the quality care that we want to. So
Right.
Pie in the sky would be having more co-located services. Reality is paying staff appropriately so they stay here, or we can recruit, good quality staff when we have the openings.
Yeah. Okay. Thank you. Go ahead, Art.
Yeah, more question for you, Lori. Does Blueprint for Health appear in any of?
So it's, I saw you going through the book. I don't actually see it in the DIVA narrative, but I know it's here. So,
I'm trying to find it.
so everyone hold on. We're just going to look for the proper documentation. What, Leslie?
Slide 24 in your presentation had some numbers.
In what presentation?
Dr. Soren.
Oh, right. Yep. So hold on. Let me just see if it's in the DIVA.
It's not in the DIVA talking point.
It's not. Okay.
It's not in where, Daisy?
It's not in the DIVA talking
Okay.
point.
So then where we need to go is to the witness list.
Okay, all right.
And go to John Sorian. And then the presentation is on.
Listed as something else then?
It's in AHS's
AHS's budget.
A blueprint for health presentation supporting access to mental health.
Can you direct Art to that, Leslie?
Yeah, no, that's
That's
fine, but I would
okay.
think we would all want to see, where it appears in the budget. I mean, maybe not, but
So it's under Agency of Human Services.
okay.
So we can,
We haven't seen that yet.
So, okay, so this is a piece of the Agency of Human Services budget.
yes,
And this is the piece that it is.
Yes.
Okay,
That was in there.
That's
Yes.
fair.
sorry. We've been switching through a lot of different testimonies, today, so we're trying to get all on track here. Any other questions for Ashley?
Just look.
Ashley, thank you very much. Appreciate all you're doing for Vermonters.
Thank you for having me. Have a good rest of the day, everyone.
Thanks, you too. Kristen, would you introduce yourself and then love to hear what you have to say.
Hi, I'm Dr. Kristen Connolly, and I probably should give some background before I launch into kind of sharing some information in that I've lived in Vermont since childhood. I crossed just over the border into Williamstown, Massachusetts for college, and then came back for medical school, where I also attended pediatric residency. And I initially started my primary care practice in Franklin County in 2013, and then transitioned to Timberlane Pediatrics when the owner of that practice closed that practice in end of 2015. So I've been at Timberlane Pediatrics since in Milton, which is beautiful because it enables me to serve that catchment area that I was connected to, but also still be connected to where I did my training. And just to start off, I just want to thank you all. Thank the House Healthcare Committee for the opportunity to talk today about the importance of care coordination within the medical home and voice my very strong support for the proposal pursuant to Act 167. Again, I'm Kristen Connolly. I'm a pediatrician at Timberlane Pediatrics. I'm also a member of our AAP Vermont chapter board and a member of our Vermont Medical Society. Our practice.
Can you just say on the first one what the abbreviation stands for? I think you said AAP.
Oh, American Academy of Pediatrics.
Thank you.
Yeah, absolutely. And interrupt me at any point if I don't clarify some of those. Our practice is part of Primary Healthcare Partners, or PCHP, which includes several pediatric and adult primary care practices in Vermont. And our pediatric practice at Timberlane has 3 office locations in Burlington, in South Burlington, and in Milton, where I work and I serve patients from Franklin, Grand Isle, Lamoille, and Chittenden counties and beyond. Our practice provides care to almost 8,500 children in the state of Vermont, including 430 infants born just in 2022. And I personally am primary pediatrician for about 1,300 or 1,300 children, and about 1/4 of whom have complex chronic disease and 1/3 with non-complex chronic disease, defined by the Pediatric Medical Complexity Algorithm, or PMCA, which is, there's a lot of different ways to look at medical complexity, but this is one of the ones that's emerged in the pediatric realm. And with this experience, I have really great insight into what effective care coordination looks like. We know the impact that adverse childhood experiences, or ACEs, have on the health and development of children now and for years to come. And if we have ever seen the impact of those stressors, it was condensed through the COVID-19 pandemic. In this era, we're seeing staggering mental health needs in our children. Our schools are understaffed and trying to meet needs that are greater than ever. Our state's children's hospital is beyond capacity and has temporarily closed referrals for autism spectrum disorder diagnosis, evaluation and diagnosis, for eating disorders, and for transgender health. Psychosocial stressors, including financial, food, housing, and transportation insecurity, have been made worse by the fallout of the COVID pandemic, and substance use has increased. Even basic healthcare coverage is unaffordable. Childcare is more inaccessible for working families. And those of us in primary care are helping children and families now navigate all of it. And we need all the help we can get. Complex health history significantly impacts the health and well-being of our patients at baseline, and navigating the systems intended to support patients and families, which are not always family friendly in design, regardless of intention, adds additional challenge. I have made many calls personally to advocate for my patients to support insurance coverage for such basic needs as inhalers needed for severe asthma or specialized formula needed for an infant with severe gut inflammation to get appropriate nutrition and grow. And each time I thought to myself, if I, as a pediatrician, am struggling to navigate these complex systems just to get needed treatments, such as even to sustain breathing and nutrition, how hard must it be for families? In 2022, just prior to when the COVID pandemic hit, I helped organize a team with representation from our medical home, UVM social work, and children with special health needs, or CSHN, to meet with families of children with especially complex health needs. And despite all odds that come with adjusting to the realities of the pandemic, we continued care coordination meetings that year. That work enabled us to identify and meet patient family needs at home, to navigate complex hospital and health insurance systems, to improve access to community resources, and connect multidisciplinary teams, including healthcare, community service, and school providers. When previously we had to be reactive, we were able to be proactive by better connecting these teams and identifying point people for patients and families to connect with when acute needs did arise. The mother of one of my most medically complex patients born with a genetic disorder and congenital heart defects said of her experience, "We have many specialists here in Vermont and at Boston Children's Hospital. Over the last 6 years, Timberlane Pediatrics has been a huge asset to my daughter's healthcare when they started their complex care clinic. It was a huge weight off my shoulders. The care coordination has been absolutely amazing. Without it, I would have probably lost my mind due to the complexity of my child's health. I will be forever grateful to the Timberlane Pediatrics team for their care coordination." And if I could bring her in to meet all of you, you'd understand why this is such important work. Funding for care coordination through Blueprint for Health has supported and improved care coordination, panel management, and integrated care within our practice. We initially had an exceptional Blueprint community health team social worker embedded within our practice, and later transitioned to utilizing Blueprint funding so we could vet and hire our own care coordinator integrated into our practice. The ability to have a co-located care coordinator really makes solution-focused work more effective when families are meeting that person for the first time as part of their trusted medical home team. Another remarkable example of effective care coordination that we are lucky enough to be connected to is DULCE, or Developmental Understanding and Legal Collaboration for Everyone, which is also referenced in this proposal. DULCE began in 2016 with 7 sites nationally, including Appleseed Pediatrics in Lamoille County here in Vermont, and expanded in 2019 to 3 additional sites in Vermont, including Milton and South Burlington offices of Timberlane Pediatrics. The goal of DULCE is really to build on what we already do in pediatrics by providing a systemic and proactive intervention model embedded in the medical home to provide maximal support for children and families from that very first newborn visit through 6 months of age. And as over 95% of Vermont infants receive routine healthcare in that first month of life, this is an exceptional opportunity to engage families early, provide early screening to identify major risk factors, and to ensure families are connected to the supports that they need. Our DULCE team in Milton has supported newborns of 348 families since implementation in September of 2019, including through the pandemic. And our family specialist is embedded in our medical home and attends all well child visits with us through 6 months while promoting parent knowledge, assisting with screening to identify and address social determinants of health, and by helping families meet basic needs. For those families with ongoing needs by 6 months, the model provides an individualized bridge to supports in and outside of the office, such as parent counseling, childcare access, food or housing insecurity supports, children's integrated services, or even our own office care coordinator. Our team's strengthened by our medical legal partnership with Vermont Legal Aid and community partnership with NCSS in Franklin County, and Milton Family Community Center, with whom we meet weekly. We know from national data around DULCE that great data shows that direct communication between the medical home and medical legal, and community partners increases connection to resources, improves well visit utilization, decreases ER use, and improves patient satisfaction with services. Families in our Milton office said of their experience that having the family specialist in person at visits was extremely valuable, and having adequate knowledge and all resources available to me helps ensure that I can choose the things that are right for my family. I have seen time and time again how care coordination, particularly when embedded in the medical home, benefits patients and families and streamlines communication and processes within very complex healthcare systems. In primary care, we provide very high quality care at relatively low cost. And still we struggle to obtain rate increases from payers, including Medicaid, with downstream impacts on difficulty recruiting physicians into primary care, challenges hiring and maintaining staff in primary care practice, and ongoing threats to the sustainability of primary care. The uncertainties that come with Blue Cross Blue Shield recently pulling out of our ACO OneCare is further destabilizing to primary care practices. We persevere despite these challenges because our patients and families matter, and the care we provide makes a difference in their lives while improving the health of our families and communities. I implore you all to help support this proposal and increase funding for care coordination, including the Blueprint for Health and expansion of Dulce, and to support inflationary increases in Medicaid reimbursement for primary care, as these measures are vital to sustain our critical work supporting Vermont's youth. And I thank you again for the opportunity to speak before you all.
Great. Thank you very much for your testimony and all you do. Sounds like a pretty amazing practice that you all have. So I'm going to ask the same question I asked earlier. What would it mean if we also increase the Blueprint rates directly to the providers?
It's that piece alone is incredibly beneficial because that enables us. Unfortunately, this work that is so crucial is not supported by insurance. So it's work that we do because we recognize the impact it has on health incomes. And the only funding stream we have to support this work right now really is through the Blueprint and through that extra funding. And still it's, not enough. Our practice has 3 locations. And right now we are in a position where we have 1 care coordinator trying to support all of that work, and we're trying to hire a second, but we still have minimal funds. The difference is immense in terms of our ability to do this work and to have enough support for the number of patients we have.
Great, thank you. Any other questions? Topper, Topper.
Thanks for coming in.
For having me.
We've heard a lot from Timberlake. I'm just wondering about the rest of the state.
Well, we're hearing from Rutland next.
Well, and I worked in Franklin County Pediatrics. I can vouch for that. Before I worked at Timberlane, where we had CHT resources as well. And it was hugely impactful, again, whether it be to support economic strain for families, homelessness, mental health. This is a model that I have used throughout the time I've been in practice. And unfortunately, the funds have not increased proportional to inflation and in proportion to the immense increase in need we've seen over these last few years. You've seen it all over the news, mental health impact, and we know the data we're seeing in the state in terms of, all these social determinants of health. And we really can't do this work without funding. We continue to do it, but we are spread so thin, and families really need this. And we know our outcomes are better when we do it the right way.
Leslie, and then Daisy.
Well, thank you, Dr. Connolly. I'm just wondering, this program is from 0 to, it's pretty weird. I have to look there to look at whatever. So the program is designed from 0 to 6 months. And what I'm hearing is that you're stretched really thin. If you had your way in the world, and would you expand the program beyond 6 months? And would that be beneficial? Or do you make enough of an impact between 0 to 6 months that you're really pleased with that? Is that a logical question?
Yeah, absolutely. I mean, I think the beauty of Dulce is really that it's universal. So previously, our systems are really set up, unfortunately, that we have to react to crisis. And primary care, a lot of our focus is trying to focus on preventive care. The beauty of Dulce is really that we have the same screening, the same support for all families through 6 months, so that we can identify those at higher risk and ideally by 6 months connect them to the various supports they need and the channels they need, which may look very different family to family. So by really focusing universally on those first 6 months from birth, the idea is that then we can individualize those supports for families that do have ongoing need. And I think that's really the beauty of Dulce. It's been such a phenomenal asset to our practice. And especially through COVID, I don't know where we'd be without it, truly.
So if you could just off a blink response, what percent of the your pediatric practice that you see between 0 to 6 months get identified and need more services?
It's a hard question to answer because the pandemic kind of flipped everything upside down. And so the nice thing is sometimes, early on, we're connecting a parent to supports outside of the office. And so, for instance, our Edinburgh postpartum depression screening, those positive screens have skyrocketed. Postpartum depression has gone up immensely through COVID. So there may be families that our family specialist has connected those moms to a counselor or to those supports. And so they are continuing to get those supports beyond 6 months, but it's not necessarily a new referral that has to be placed. And we are just then able to do the follow-up and check in at those well visits to make sure they're, they have that ongoing support. So there's kind of like the ongoing need in terms of needing a new referral or having someone who's really integrated in to address ongoing acute need. And then there's kind of the maintenance of the supports that have been put in place through the program. And I can certainly get you the numbers of kind of the breakdown of all of that and what supports are put in place, because we do data collection on all of this in a HIPAA compliant, confidential way to track all of those numbers and outcomes, which is really, really helpful to help continue to improve quality in the work that we're doing.
I think that would be great I want to support this. And if we have data behind it, it just really helps.
Yeah, VCHIP, Vermont Child Health Improvement Project. It used to be, a national project, but shifting over to VCHIP. And so we have monthly quality improvement meetings and weekly meetings with our team to, do confidential case review and try and all work together to solve some of those issues. But the monthly quality improvement is really looking at all that data. So we can absolutely get some of that over to you if that would be helpful to review.
Thank you.
Yeah.
Daisy.
I wonder if you could perhaps orient me a little bit with your program and how orient your program within the practice and your partnerships. I know you mentioned NCSS, and I'm really curious who some of your collaborators are.
Absolutely. So for Dulce, typically there's a community partner. In our office in Milton, we're connected to NCSS in St. Albans in partnership with Milton Family Community Center because our catchment area is so large. So the director of the Milton Family Community Center is often engaged as well because that's such an important community support for our population, as is NCSS. In our South Burlington office, their agency that they're partnered with is actually Lund. And again, Vermont Legal Aid kind of works with everyone universally. And we have a dedicated member of our team that is from Vermont Legal Aid just to navigate some of those issues, because as physicians, we've learned to do a lot of social work, even though we're not social workers. We have learned to navigate complex insurance systems. I have made so many calls and pleas to insurance companies. I have made, so many calls to subspecialists and to community providers. But it takes such an immense amount of time, and being able to centralize that in a direct connected way to the family is just so critical. So the nice thing about Dulce is the model is set up that way to begin with, which really streamlines some of that collaboration.
You said catchment areas, and that caught my attention because I'm aware that the FQHCs also fall into catchment areas. Does this align with that at all?
So I guess I say catchment area in the sense that I don't have defined geographic borders. I have some patients that come from 2 hours away to Milton. I have, it's when I say catchment area as a pediatrician, I say like, where is the kind of geographic location where my patients come from? And in our Milton office specifically, it is such a geographically large and diverse population that we really need to think creatively sometimes, because children may come from a lot of different school districts, a lot of different, counties with different mental health agencies, with different community partners. So it's really nice for our practice in Milton to have collaboration between Milton Family Community Center and NCSS, where we can really work collaboratively in that work, knowing that patients really come from, all different areas.
But that's not a requirement or certification or anything of the program.
No, it's universal for any patient who comes to through our practice. So that's the really nice thing, is it is not defined, there's no exclusionary criteria. It's any newborn from starting at birth that comes through our practice has these supports and services.
Thank you.
If we could do this, if my pie in the sky is if we could do Dulce ad infinitum for all ages and just continue it forever, that would be amazing. I think that for the way Dulce exists right now, and kind of, again, it kind of being the hub where then we kind of figure out what direction people need to go in. I think if more practices can utilize this model, that's the first goal.
Great. Thank you so much, Dr. Connolly, for your time, your testimony, and for all your work. We really appreciate it.
Thank you very much. I really appreciate the opportunity.
Sure. All right, Doctor, I'm just gonna say I'm gonna get it wrong. Dr. Peter
Hogenkamp.
Hogenkamp, thank you. Welcome, and thank you for staying with us.
I absolutely enjoyed listening to Dr. Connolly. She did a brilliant job.
Yes, she did.
And I have to agree with everything that she said. So I'm actually probably a good person to follow her, because I'm a family doctor, and although I do see a few kids, I mostly take care of older folks. And that started when I was in residency. I just had a particular interest in geriatrics, and I moved to Rutland County 27 years ago. My wife and I came. We had just finished our training in Syracuse, New York. We're both from the Syracuse area. But I've been a big skier my whole life, so I dragged her up to Vermont 27 years ago. And we started a private practice here across the street from Rutland Hospital. And so we've been doing this for 27 years now. And our practice has evolved such that Lisa takes care of a lot of the younger folks and the kids, and I take care of a lot of the older folks. And I really enjoyed doing that. And it's interesting because I think older folks have a lot of the same issues that younger people do, and that they require a lot of help. They require a lot of help. One of the things that I've learned in 27 years of practice is that, when you're in residency, you have this tendency to think that the world revolves around you as a doctor, and that, all these things that you decide to do, all these orders you make, all these medicines you prescribe, that these things are just going to get done. But in reality, none of those things happen. I was reading a study recently, and it was talking about, on a nationwide basis, that probably about 2/3 of doctors' orders are followed on a best case scenario, which means that 1/3 aren't. And in Rutland, which you guys I'm sure realize, which is not one of the richer communities in the state, our statistics are probably worse than that. So that's the reason that I volunteered to testify before you all in support of the community health team and the blueprint from health, because these people are just invaluable to us. And I've always believed in the power of the narrative. I love to read, I love to write, and I think that people remember things when they hear it in a narrative. So I got a couple stories for you. I had this one patient, I'll just refer to him as Clay. And Clay was still is a guy who was in my practice. And Clay probably had in the average year, maybe 2 or 3 hospitalizations and at least 6 or 7 emergency room visits for substance abuse. And I really tried to work with him as best I could. but a lot of the things that I wanted to do just didn't get followed up on. However, once we got him hooked up with the community health team, and I want you to know that the community health team found him a place to live. He wasn't able to afford his medications, so they were actually able to utilize programs to get his medications. They got him to quit smoking and drinking. And since that time, he has not had an ER visit or a hospitalization. And you guys know well how much money ER visits and hospitalizations cost.
Yeah.
If I'm not a politician in any way, but if I were a politician, I would try to focus on reducing ER visits and hospitalizations, because this is where we really fail in medication. This is where we fail in medicine. I just came in this weekend, or this week after a weekend. I saw on Monday morning, one of the triages that came across my desk that one of my chronically ill patients had been admitted to the hospital again. And the problem is that none of the things that they had done in the last hospitalization, which was only a week ago, none of the medicines that the doctors had prescribed, the patient just didn't get them because she lives alone. She doesn't want to bother her son. So she didn't start pick up the prescriptions for the new medications she was on. She just went back home. My office called her. They set up a hospitalization visit for the end of this week. And she didn't make it. She was back in the hospital. That hospitalization is going to cost what? $20,000, $30,000. It was completely avoidable. All she had to have is somebody to go pick up her medications and put her on the new medication that she didn't do. And that might be a slight simplification, but in reality, this is some of the biggest problems that we face. After 27 years of medicine, I have a pretty good idea of what to do for my patients. The problem is that once they leave my office, I lose total control of what they do. And that's where the CHT comes in. We have a particularly wonderful CHT person, Sharon Decato, and Sharon has just been absolutely outstanding. She's stretched way, way thin, but she's really able to help these folks out. Just the way I look at it is she gets them to do all the things that we want them to do, that a lot of times these folks just let slide. And the problem with that is that they end up back in the hospital. They end up in the emergency room, and you don't want that. It's the amount of money. I had the misfortune of cutting myself with a chainsaw this fall.
That is unfortunate. I'm glad you're still here.
But you know what? It was great from the standpoint that I've been very fortunate to be a healthy guy. And when I got the bill from the emergency department, I almost fell over. Do you know what it cost to cut myself with a chainsaw? I mean, I could have bought 4 more chainsaws with the bill I got from the ER. Emergency room care is tremendously expensive, and it needs to be avoided. And so the way I look at CHT and the blueprint is they're the folks that are going out and making sure that all the care that we've already ordered or directed is getting done. I've got a number of great cases. I won't bore with all of them, but I want you to know what these folks do. We had a lady here who got divorced. She lost her insurance, her home, and her ability to pay for her medications because of the divorce. And the community care team got all those things back. If none of those things happened, she was going to end up in the hospital. We have a patient I've taken care of for a long time. He got kicked out of the Gables, which is interesting because that's where my mother lives. And my mother had been complaining about him for a long time. Peter, what are you going to do something about this guy? It turns out that he was a drinker, and I've been working with him about his drinking for a long time. But ultimately, he got kicked out of his place to live, and he ended up in the hospital. And the community health team found him a place to live. They got him to quit smoking. They've got him rides to and from the doctor's offices and the place he needs to go. I realized, I remember when I was in medicine, when I was an intern back in the days in Syracuse, and when you're an intern, you have to do absolutely everything. I remember telling my chief resident one time he wanted me to call up and get this person a place to live in a hotel. And I said to the chief resident, I said, well, is this really in my job description? He goes, you're an intern. Everything is in your job description. And when I graduated from being an intern and became a primary care doctor, I realized that those things are in the job description of every doctor, and they continue on as part of your job description. And I still do those things. The community health team does them much better than I do. They know a lot more about those things. But as Dr. Conley was pointing out, I make all kinds of calls to people to ask for prescription coverage, to ask for a nebulizer treatment, to ask for an air conditioner. And these are the types of things that, although I'm perfectly capable of doing, if I'm doing those things, I'm not seeing patients. And as you know, Rutland is a provider, is an area of provider need. The other thing I wanted to talk about is Medicaid payments. So my wife and I, we choose to participate with Vermont Medicaid because, that's how we feel we should. We feel we should. But we have to limit the number of Medicaid patients that we can take because we can't afford to otherwise. So I have now, as I mentioned to you, I have 30 years of experience as a physician. I'm hoping to work another 5 years or so, but ultimately we would like someone to come into our practice. We take care of, I think we have about 5,000 patients between my wife and I and our 3 nurse practitioners. And if Lisa and I just kind of, close up shop, I don't know what Rutland County is going to do. I don't. And we do have a federally qualified medical clinic. I happen to be a patient there, but we need providers in this town desperately, and I'm sure that that's the case for a lot of other places in Vermont. Increasing Medicaid payment is going to help me attract somebody to keep this practice going. I would love to see this practice going. My daughter in college says she wants to be a doctor. We'd like to keep it going for her to come back and take over the practice. No pressure on her. But increasing Medicaid funding is going to be a big part of that. I really feel like as a physician, I should see Medicaid patients. I can't just take, private insurance, and most of my patients are Medicare because I take care of, as I mentioned, an elderly practice. But it would be awfully nice if we could actually get paid for it in a reasonable fashion. We lose money on Medicaid patients. That's the simple fact of it. That's the reason a lot of physicians don't take it. But if you made it a little bit more financially feasible, these Medicaid folks would come to a doctor's office as opposed to using the emergency room for primary care. Again, I'm going to go back to this theme that emergency room care is expensive. Cutting my knee cost me like $2,400. If you've got a patient who has Medicaid and who can't get a primary care provider, and this is very, very common, as I'm sure you are aware, they go to the hospital for a urinary tract infection, which I could deal with for $100 in my office. You're spending $1,800. It doesn't make any sense to me whatsoever. But until you structure Medicaid fees differently, you're going to continue to get that because not every doctor feels like, like my wife and I feels like, it's our obligation, kind of like civic obligation to do that. Yeah, I'm sure there's a lot of Vermont doctors do, but a lot don't. And if you made that a more feasible thing for them to take Medicaid, it would save you money in the end by reducing Medicare or ER utilization. Mm-hmm. So that's pretty much all I have. If you have any questions, I'm happy to answer them.
Great, thank you. I think we do have some questions. Brian?
I have questions for both of the doctors, if you're both willing to answer. You answered one of them, I think, just now, Dr. Hogenkamp. Hogenkamp. My glasses are off, but Hogenkamp.
That's okay. Yeah, Hogenkamp, you got it right.
Okay, good. I think you said that it cost $2,400 for the chainsaw accident.
Yeah.
Yeah, which is expensive. That's like more than a month's salary for some people.
I know.
So,
I was going into the office to sew it up myself, but my wife wouldn't let me.
Yeah, I can relate. I was doing EMDR on myself the other day instead of going to a therapist. So I'm a clinical social worker in my regular job. So the question I have is, like, it's around the barriers for access. Like, we heard that one of the barriers is that some practices have to limit the amount of space for Medicaid because you can't afford to have everyone be Medicaid because the rates are too low. So, right. So I heard that. What I'm curious is if you have ideas about how we might reduce the barriers to access besides raising Medicaid rates. For example,
So, Dr. Connolly, I think you need to mute yourself.
Both of them.
Okay, I think that worked. Thank you.
There was some kind of echo. So specifically, like, I'll throw two things out there and then you can choose how you handle the question. Like, one is, how would it affect primary care access if the state just guaranteed primary care? Like, if we found a way to pay practices some base amount of money so that you could just guarantee access to primary care without copays or deductibles to anyone, regardless of their insurance. And number two, how is Medicare Advantage plans affecting access to healthcare for people as more people shift from Medicare to Medicare Advantage? Those are two specific questions that if you had anything to share.
Kristen, you first.
So we don't have many Medicare patients, unless they're, on a renal transplant list. There are very rare exceptions. I don't know anyone in pediatrics that limits Medicaid in the state of Vermont. I mean, how could you? We can't. Like, it's like children. Like, that we don't have control over it. Like, we can't, because this is their only line of care, which is much easier for certain practices in certain areas than it is for others, which is why when the practice I was in Franklin County in 2013, when the solo practitioner I had joined decided to close her practice, and at the time Mousetrap Pediatrics, which then became NMC Pediatrics, bought by the hospital, which then the hospital dropped them because they were not making enough money because they had a high Medicaid population. And now they are Monarch Maples, and they are part of PCHP with Timberlane Pediatrics. They had closed their Milton location the same time. And then another provider in St. Albans left. So 4 pediatricians basically all at once left in a very high Medicaid area. So like 6,000 patients were left without a medical home. That's one of the beautiful parts of being able to expand to Milton for Timberlane, because I was able to continue to see a lot of those patients, but the need is high. And unless we think through creative solutions to those models, particularly in pediatrics, you've probably seen all over the news, pediatric hospitals are also decreasing their number of beds, which led to a crisis worse than any time during the pandemic in pediatrics, because we didn't have enough beds, because it's not cost effective for hospitals to have pediatric beds. So we had babies with RSV, respiratory syncytial virus, which we hadn't seen in a couple of years. No one would ever have set out to do the experiment where you don't see germs for a couple of years and do them all at once. And a flu season that hit early, COVID still hitting with new variants. And we did not have enough beds in New England because pediatrics is not affordable, because pediatricians see everyone. And I'm going to be full out that we need a system that everyone can afford. We need a system that is equitable. And we need a system that doesn't leave anyone in the lurch, because it's true, when you have a system like that, the costs end up increasing. And because the hospitals are then having all these patients come in for acute needs that could have been handled by us, they drive up insurance costs for everybody else. And it's a vicious cycle. MVP just increased their cost for a base plan thousands and thousands of dollars this year. So the out-of-pocket cost for a gold plan through the health exchange would be, with the premiums plus the insurance, if it's not a super high deductible plan and it's only like $3,000, it's like $30,000 to $40,000 for a family who's not on Medicaid to pay for private insurance right now. That is not an option. And I will say, everyone who's in primary care, unless they're connected to a hospital or a federally qualified health center, we're also paying for our own insurance through this model. And people say, well, you're in medicine. Like, how is this possible? Like, shouldn't you have health insurance? And no, we are part of the same system. And our staff that we're trying to hire, we have to hire them not connected to a hospital when the benefit cost is so much higher for them. And it's impossible to compete with hospital systems. I mean, literally, for a hospital to drop their pediatric practice says a lot about the state of primary care sustainability, and says a lot about the sustainability of a high Medicaid area. And again, we don't limit Medicaid, but it is every year we go, okay, can we make it? Every year we go, okay, what's the variable coming at us? And something has to change, because we cannot leave our kids and families in the lurch.
So just to clarify my earlier comments, we actually do not limit pediatric Medicaid at all. We limit adult Medicaid. But we take in fact, a great majority of our kids who are in our practice are Medicaid. But Kristen's point is really, really strong. And to answer your question about the Medicare Advantage plans, we've had good luck with Medicare Advantage plans. I think they offer, they pay for more for their patients than the straight Medicare. And I happen to notice that I do glance at the patient's insurance every once in a while. I never used to, but now I do, just because I can, I hate to prescribe things that aren't going to be covered or paid for. So I'll glance at the patient insurance just so I know what to prescribe. And I would say that the Medicare Advantage plans are on the increase for my patients. And my secretary actually confirmed that to me the other day. In terms of guaranteeing primary care for patients, I really wasn't clear about what you were proposing to do. You talked about just like giving a certain amount of money to practices for a family to take care of them and not bill insurance. Is that what you're saying?
Yeah. That's what I'm getting at is how might it increase access to care and also reduce administrative burden for practices if the state found a way to publicly finance primary care and just pay primary care doctors enough to keep their offices open, versus you playing the game you have to play of coding and billing and, and then you would also have that benefit of like, for example, if you buy MVP's cheapest plan, it went up like $100 a year per month or something like that. So now for me, it's $674 a month. Like if we were deducting the amount of primary care out of that would also lower the premiums for your staff. So if we took a step in that direction, how might it reduce the burden and increase access? That's sort of what I was getting at.
And it is off topic of what we're talking about. And so don't feel you have
I'm
the
sorry.
answer. But if you want to provide an answer, that's great. I do just want to make sure we're done at 3.
This is where we put in the plug for universal healthcare would be amazing.
Well, Dr. Hogenkamp, did you have anything you wanted to add to that? And if not today, it's fine. We could talk about it another day.
Yeah. So I have the great situation that I get to just practice medicine because my wife, Lisa, takes care of all the finances of our practice and she does a wonderful job. So I don't really know a lot about finances and stuff like that, but I will say this. I know that our practice provides care very cost effectively when we're compared to hospital-based practices or FQHCHRs, much more cost effective. So I really think there is a role for private practice in the state of Vermont. That said, I'm also a big proponent of universal healthcare. I would love it so much that I could go to work and just everybody has the same insurance. Everybody, I know what's paid for, I know what isn't. I think that would make it a lot easier. But I realize that's not what we're here to talk about today.
Great, thank you.
Yeah.
Art,
No, I'll pass.
you sure? Okay, great. Thank you both. And I want to say the examples given on how the community health teams help your practice and help you as providers was extremely helpful. And we will definitely remember those as we consider this proposal. So again, thank you very much. Thank you for taking care of Vermonters and thank you for being here.
Hey, cheers. Best of luck.
Thanks. Have a good weekend. So everyone, just to wrap up for the week, thank you. I know it was a lot. Appreciate the good conversation, especially this morning. What I want to check in with is we have amendments to the compacts from Ways and Means that we need to vote on before the House floor on Tuesday at 10. Can people be here at 9:15 on Tuesday?
Okay.
I think so.
Okay.
So, yeah.
So the plan will be for Ledge Council and the report of the bills, the amendments out of House Ways and Means. We'll just hear the bills. We don't need to do an official vote. We can do straw votes on all of them. And then we'll be prepared to vote.
What bills are they, Laura?
These are the compacts. So I want to talk once we go off air with the 3 reporters of the bill, just process on the bills. But so we will start at 9:15 on Tuesday. Leslie?
Did I see that was going to appropriations? Those
No.
compacts? Okay.
I don't think it is, but I will check
I
on,
saw that somewhere.
Yeah,
Okay.
they absolutely
they
did.
got sent to appropriations?
All the bills for Tuesday have gone.
No, we have time.
Okay.
You want me to wait inside?
No, that's fine. Okay. Then scratch all that and check your email this weekend and what time we're gonna start on Tuesday.
Okay.
So I apologize, I missed that section. And then we will do a lot of budget next week. We will finish our conversation on suicide prevention at H2:30. And we will vote on that and we will vote on COVID flexibilities next week as well.
So we are meeting, you want to talk to us after the meeting or no?
Yes, let's go off live and then
Yeah.
let me check on